Meeting will please come to order. Could I please ask Councilor Taylor to do the invocation?
Bow your heads. Heavenly Father, we thank you so much for this day, for this opportunity to be here to serve the people we're elected to serve. We pray that you will be with us throughout these proceedings and let us make decisions that will be helpful to our constituents. Be with the servicemen and women, both here and abroad. Protect them as they're standing in the gap for our freedom. Pray that you will give those in attendance traveling mercies as they go home. For it's in your name we pray. Amen.
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 How you doing?
Honey.
Here.
Harley Buzzer. Joe Bird.
Honey.
Sean Crittenden.
Honey.
Frankie Hargis. Wanda Hatfield. Max Jordan. Dick Lay.
Honey.
Mike Shambaugh.
Here.
E.O. Smith.
Here.
Janice Taylor. Here. Victoria Vespas. David Walkenstick. Brian Warner. We do have a quorum.
Thank you. Has everybody had the opportunity to review the minutes?
Yes.
Motion's been made to approve and seconded on our minutes. All those in favor say aye.
Aye.
Thank you. Okay, we'll start with our reports. George, would you like to start us off today?
Good afternoon. I think you have our report there in front of you. A couple of highlights. We have started a flu room. We started giving flu shots. We have a dedicated flu room just past the canteen on the main hallway there where patients don't have to go through clinic or sign up to see the doc. You can just go down to the room. They'll register you there and get your flu shot, and you can be back out the door in just a couple of minutes. Finally received from area office a definitive, an updated timeline for construction on the emergency room. They're telling me that October 26th is the tentative start date on construction, with March 25th as a tentative completion date on that project. We've got an effort. We're making an effort to get to clean the registration files and delete ineligible patients, and we've sent out so far 257 ineligible patient letters to folks, and these are people who either are truly ineligible or came in and were seen without their actual eligibility documents, and that'll give them a chance to come in and clear that up. Registration is also pushing the text messaging. We have appointment reminders that go out by phone. We have added the text messaging feature to that. Seems like people are more in tune with text messaging than they are the phone calls anymore, so we're trying to stay up with the times and make a dent in some of our no-shows. One of the things that I was asked to bring up is, and I may have brought it up last time, was our 3D mammography got accredited earlier this fall, so that's a big deal for that group in radiology. Any questions?
Anybody have any questions? I'm sorry. Oh, Councilor Buzzer.
George, what kind of a percentage do you have on no-shows?
I'd have to look because each clinic has a different rate. I can look that up and.
That'd be interesting to see.
Okay.
And the other thing is on the ineligible patients. How often do you do that there? Do you have a certain time, or is it just one of those things?
No, I don't know what prompted that, but they had come up and asked if we could start sending some letters out to try to get folks to bring their eligibility stuff in, or let them know that they are truly ineligible and can't come.
I see. Are there any tests that you do there at the hospital, George, that like hepatitis tests? Do Do you test patients for that?
We do for Hep C, yes.
Okay. And the question for Dr. Grimm, when he comes in, what about mercury? Do they do a test for mercury? I know I was at a seminar this week, and it said at Tahlequah we were automatically doing those, and I'm wondering if you do them there or for lead, not mercury, but lead. Yeah. If we're doing that on our kids.
Not that I'm aware of, no.
Okay. Okay. Thank you, man.
Any other questions? George, thank you so much.
Thank you. But I'll find out on this test for you.
Okay. Yeah, I'd like to know. It'd be interesting to see.
Hey, Dr. Graham.
Good afternoon. I'm going to hand you out the new report. Next month, we're going to try again to make sure this is the one in your packet. You seem to have a communication problem. Internal to us. That didn't have anything to do with Gail. I'll wait till you get those in your hands real quick and just call your attention to one thing very quickly. And it has to do with the fact that you all had asked us for some additional information. So on the back page of this one, where we had, last time we had, the top reasons for visits by facility. We'd also been asked about pharmacy prescriptions and things. So we have that on there for you this month. And we will either use that page or maybe an additional page in the future, to do some rotational things, through the report, or if there are special requests at times, we can do that. I'm going to mention real quickly a flu clinic here in Tahlequah because we have a lot of people, October the 22nd through the 26th, and if you'd like, I can send this to Gail. 8 a.m. to 6 p.m. at the main entrance of the hospital. You can, come right up to there to get a flu shot. And then on Saturday, October the 27th, we will have a drive-through clinic here in Tahlequah that is at the Peace Pavilion behind the Cherokee Nation Capitol building. And that's, vaccinations are going to be for ages 3 and up at that drive-through flu clinic. So regarding mercury and or lead testing, Councilor Buzzard, we don't do it as a standard screen on 100% of children right now. It's something that we continue to look into, and if there's any reason a doctor believes there might be something like that, they order it. But I don't believe we're doing it broad-based screening, just on 100%.
Well, that was just a question. I heard something about that in a seminar this week. Well, you may have heard it too. I just wanted to see if we were doing that broadband.
And I'll take any questions you have. You have our old report. You now have the new one, and you're starting to get used to the way it looks. So if you all have any questions about anything, I'll be more than happy to take them.
Any questions? Councilor Buzzard.
Just looking, this is an interesting report on the back page, and I'm wondering what caught my eye right off the bat was the 20,000 prescription down at, well, I guess it's at Muskogee. Is there some reason that is really high? I know we got a lot of patients there, but then you look at some of the other ones, they're not quite as high.
You always ask me those difficult questions, Councilor Buzzard. I don't know the answer to that, and I'll look into it.
I guess my other question is, do we have how many pharmacists do we have there at Muskogee?
Don't know that off the top of my head. I can potentially look that one up for you, though, with some of the information I have.
But if you look at WWH Maine, you only have 15,000 up there.
Yeah.
I have a feeling it's really a time bar. Okay, well, I just wondering. That's all.
Okay. I'll look those up. We try to get those answers to you, and Jeff Sanders is here too, so
Okay.
he's got that down, and we'll do a little research
Well,
on
apparently they're
that.
doing a good job, because we don't, I know,
They are. I don't know if that's just totally volume or
okay.
Other places like that?
what. And that's the thing you need to look at on some of these graphics too, that we're presenting to you this way. You'll notice that the bottom axis is different for the different size clinics. It's not always gonna, look exactly the same. We're trying to make the graphic look similar, so at the bottom you'll see, different numbers.
My thinking was too that, like this clinic here, are they filling prescriptions for call-in prescriptions? Maybe that's the reason.
If they're counting the call-in prescriptions, that very well could
So
be, because
that's
that's where
kinda what I
our
thought.
refill center is.
Yeah, for the refill center, they're refilling a lot of
Yeah.
outside prescriptions are.
That's where our mail
Yeah,
order
okay.
pharmacy
Okay.
center is for our whole system. I don't know if that's what is being
Yeah,
counted there or not. Do you
I
know?
thought that probably was.
Yeah, I can answer a little bit for you. There's always variability between the facilities based on staffing, patient load, how many prescriptions, how sick the patients are. They may see a lot of diabetics who use a lot of medication per patient. But when you look at the report, Muskogee is our second highest prescription filling facility. Hastings is still first. We have 3 pharmacies in Hastings. We have urgent care, outpatient, and then the inpatient. And
Yeah.
between all 3, it runs about 26,000 prescriptions in Hastings. Pharmacist-wise, I think you asked about that too, and Muskogee currently has 7.5 pharmacists that work there. Now that's just the outpatient. Muskogee also houses our refill center,
Yeah.
which that's a totally separate facility, and those numbers, I don't know if they're reflected in that report or not.
But we'll find out.
Okay,
Yeah.
well, that's kind of what I
That might be an
thought.
interesting thing to show too.
Yeah,
the refill
because a lot
center,
of
if
those
it's
call
not-
in and it just goes to the refill center. Okay, well, that's fine. Thank you. Thank you, Madam Chair.
Okay. Counselor Hatfield.
I was looking through the report yesterday, last night, last week, and what's a generalized anxiety disorder? You had 2 clinics that seem to have a little high number, and I know that's kind of an off-the-wall question, but can that just cover?
I'm going to let Dr. Montgomery answer that. I may just let everyone else behind me answer questions. There's a lot of people behind me
I
today.
know it's an off-the-wall question, but it's just like, I saw those 2 clinics, I'm like,
Yeah.
it's just more stress, they're just stressed.
I think that's right. I mean, I realize anxiety disorder just reflects an emotional disturbance that's categorized by the provider as being anxiety,
Okay,
and it's a very common diagnosis.
okay. Right. Thank you. Thank you, Chairman.
Counselor Austin.
Yes, Dr. Grimm, can you give us an update on the efforts at Claremore to keep the contract health staff in the vicinity of the hospital?
I can, and George maybe can answer this one too, and I won't have to, but George and them, I know, have been trying very hard to find us a place inside the facility. We might get space. Come on up. And then you had pointed out some location closer to the facility than what we were looking at. And I talked with Gary about that. Housing has that under them, and they said if we, feel like it's an appropriate space, we can use it. I believe Steve Carey and I had him come today, and I was going to introduce him, so I'll just do that right now. This is, I'm being kind of informal today. I don't know why. It's fall, I guess. It's cold out. But Steve is the new Brett Hayes, new CHS director. And I know a lot of you have already talked to him, but if you didn't know him, that's him.
What's his name again?
Steve Carey. And you should have, and we can send it to you again, you should have his email and his phone.
Yeah, send it to
Now
me.
that we sent you. And so we were told if that space was sufficient for us, that we could use it. The only problem with that space back there, I think there's only 4 parking spaces for it, But, George?
We have made arrangements to put Cherokee Nation PRC back in the warehouse with our ladies, so they're going to be in the same place, and we have we're fixing a storefront, so to speak, for the patients to have access to both one of our PRC folks and Cherokee Nation folks, so they don't have to go back through the warehouse. They'll have a place up right off the main hallway.
Good.
How much square footage did they have and how much will they have? Just, you know, are we squeezing them down or are they getting equals, you know, same type of space?
I don't know. I don't know what the square footage was in the little room that I had offered Brett.
And you know, I will say that, you know, we all think it's more ideal to have them in the facility, if at all possible. We thought we had a way to, you know, work around it. There might have been some bumps for a little while, but as soon as health committee was over last time, you know, the chief asked me to approach IHS, George, and area director and tell them that if there was space, we would even be willing to put in a modular unit, you know, in the parking lot. Not as ideal, and they are very, very tight, you know, for parking spaces, and so they started looking for internal space, you know, so that we could share it. And I think it is ideal if we can be, you know, side by side like that. Not required, but I think it's better if we can be, you know, because some people don't always know who they're going to, you know, depending on what they're being referred to. So right now it looks like we're going to have inside space.
Thank
And
you.
does it have reasonable amount of privacy for somebody who's talking to the people in, is that actually being provided for in that space?
Actually, we've ordered the same cubicles for your folks that we ordered for ours. They all have separate individual cubicles in that area.
All right, look forward to it.
Okay.
Better than last time, right?
Yes.
Remember, we were going to be 4 miles down the road.
Good job.
Thank you,
for
George.
that. Yes. Counselor Crittenden.
Sir. How you doing, Doctor?
Good,
Hey,
Counselor.
before I forget, I had a lady, I'll text you her number,
Okay.
but she wanted me to convey her some good words for her visit to Hastings.
Okay.
But I'll text you her number. She just, I know we get into some other things here, but she was.
We always send those along to the departments or the staff too, so
Very
thank you.
pleased. And also, I appreciate the good doctors you sent the other day, short notice, to a Stillwell meeting we had, and some good information, and appreciate that. And Dr. Gann, that kind of leads me to my next question, is you gave me some pretty good data there that day about the Stillwell being on the national list. Can you update me on that a little bit?
Thank you. I think that's on the agenda for tomorrow for the Public Health Subcommittee meeting. I've got a briefing prepared for that.
Okay.
If I may defer that.
Thank you, Dr.
Yeah.
Gann.
Yeah,
We'll
that-
look forward to hearing that.
That's fine, and so we'll be able to ask you some questions tomorrow.
Yes, sir.
All right. Also, I had in my notes here, I've got to speak with Mr. Carey, and appreciate you hitting the ground running. Can you send us your cell phone? You may have sent it already, but here's a softball. Had a good lady just ask me, how many beds are there going to be in the new big facility?
That's an easy one. You're right. 0 beds. That's going to be an entirely outpatient facility. The hospital will still stay the hospital.
I thought so.
And we have 58 beds currently available, and we're looking to free up 2 others that we're using for other things so that we'll have 60.
I thought so. Thank you. And I hadn't been able to understand this, Doctor, and it's not just the health department, it's some others. But had a guy, and it's not the first guy, that has some leave built up, sick leave, vacation, and there's a policy, is my understanding, that I can't remember the hours, if it's 42 hours, 72 hours, where they need to call in or get with their supervisor and schedule it. And just recently I had a guy call or visit with them on Monday, and they said, we don't have any coverage for you on Friday. You know, and I'm not understanding if you could get me something to make me understand. I mean, in my job, like we've talked before about the lady, wasn't necessarily exactly like this, but where they have leave, and to me, in my mind, when I take a job, that's kind of like a benefit. I'm going to get some vacation time, some sick time, and I expect to, especially if I'm following policy and calling within 72 hours or whatever it is, I'm expecting to be able to use this stuff that, you know, more times than not, you kind of earn, and it kind of grows, and in my view, the coverage is not necessarily the responsibility of an employee who's earned his time. And do you have an answer to that, or do you want to look into that? Or?
I can try to give you an answer today, and then I'll look into it further, you know, and we have discussed this in the past in a different fashion.
Yeah, it was a different scenario.
And, you know, we try to keep our clinics open as, you know, as many hours a day as we can. And the other day, you know, sent me an email about us not having,
right.
You know, one afternoon we didn't have any walk-in providers, and they were then happened to be seen by the people that have a panel and full schedule, and they did work some of the patients in, but just so happened that one of those providers called in sick, you know, and the other one had a scheduled sick leave that afternoon that they had scheduled in advance. And so all of a sudden, you know, when somebody didn't show up, we had 0 walk-in providers that afternoon, and somebody complained to you about it.
Right. And I can see both sides of that.
In that instance, you know, that call in, if it wasn't scheduled, that counts as a, and I'm going to not maybe get the term right, and we're looking at changing the term because it is an excused absence, but it's one that doesn't come early enough for us to schedule anyone else to cover for it. And I think the term right now in the policy is an unexcused absence. It's really excused if they have sick leave, have time to take, but according to our policy, if they have 10 of those, I believe, right now it is, then, you know, there would be some disciplinary action
taken. Now that's sick, that's the leave they didn't call in time for, right?
Right.
And see, that was kind of different from what we were going at.
Then I wasn't sure where you were going with it. This one, it's back to we try to provide coverage. You know, if somebody else, and a supervisor, we try to do it consistently, at least within a facility, either based on seniority or rotation or whatever. If somebody else already has off and that person wants off, and we're going to end up having to, you know, close a section of the clinic or whatever, a supervisor might say no to that person if they are the, you know, the second person to ask off at that time, assuming there's only 2 providers or whatever they are, you know. So yeah, it's not a 100% right. You know, it's a benefit, and we try to, you know, allow the employees to take it, you know, when they want. And in some departments, it's easier to do that than in others.
Now, this one was a clerk, and you know, the issue we had the other day with the no drop-in doctor. Mm-hmm. Now that was kind of a last-minute deal,
yeah,
wasn't it? And you know, you're going to get sick, and if you got sick leave, call in, and some of the situation we had the other day, that's going to happen every now and then, and but I'm, you know, calling on a Monday, and you have time, and not being allowed to schedule it for Friday. I'm just not understanding it. And do you see any room for improvement on that?
I'd like to think that's a very rare occurrence, you know, but if you can get me some further, you know, detailed information so that I can look into it, I'll see, you know, specifically what's going on. But I'd like to think that's a fairly rare occurrence. I mean, we don't hear that complaint very often. I mean, is I don't know if this is the first time you've heard it or not.
Well, no, it's just, and like I said, it's not just the health.
Yeah.
It's them and myself not understanding if I have some leave here, I should be able to take it. But
It's that mix of trying to provide coverage and keeping the doors open for a particular department versus allowing staff time off, to use their leave. And, we try to not totally close something, and if it gets too low staffed, the supervisor will say no. Try to keep the services going.
all right.
I'll try to find out more for you on the specifics of it,
Okay.
if you'd like me to.
Well, and I see a lot of gray area there, and I'd hope folks would think about it some more and, try to come up with something, because like I said, I don't think the responsibility of coverage on a Monday to a Friday falls on this employee. I think goes a little bit above his head to say, we don't have coverage, but we better get some. You've fallen under the policy for the hour you're supposed to get with us, so we don't have coverage. Instead of laying it on the employee, I would think that would be a supervisor or somebody higher, but maybe we can get rid of some of that gray area. But I do appreciate you.
We do try to be consistent how we apply it. I'll say that, within a facility or a program, and let me know, and I'll look into that particular instance a little deeper if you'd like me to.
Thank you. Thank you.
Counselor Dobbins.
Thank you, Madam Chair. Dr. Grimm, on the July report, it says a little over 2,600 behavioral health visits. Is that kind of average for a month? And about how many providers do we have doing those visits?
You guys are asking some tough questions.
Just roughly.
I'll get you that number, behavioral health providers, unless somebody back there knows it off the top of your head. We have some in every clinic, and then we have a big facility that does adult behavioral health here in Tahlequah, and a facility that does pediatric or youth. Two separate facilities here, and then each clinic has a number of behavioral health staff within each clinic. So,
do our behavioral health needs escalate in the winter? So it seems as though behavioral health issues pop up more in the winter when daylight is restricted.
I'm going to say anecdotally, they probably do, and I don't know numerically in our, data if it shows that or not, but seasonal affective disorder is, something that does come up in the wintertime. There's less daylight.
So our current staff just has, if we have increased load, they just have to schedule appropriately to address that need, right?
Yes, and I'll say that we have a very robust behavioral health program, compared to a lot of tribes, a lot of locations, and I'll get you the staffing numbers for that.
Thank you, Dr. Grimm. Thank you, Madam Chair.
Okay, Counselor Lay.
Thank you, Madam Chairman. First of all, thanks to Dr. Montgomery for coming up to community Saturday. And it's good to have him up there. The provider vacancy rate, you guys used to spell that out in clinics. I think I've asked for it to be done that way again. Does it fall on deaf ears, or this is just what we're gonna get and that's it?
We'll get you that.
And I'm still short of Dr. Noah. Is that correct or not?
Is that correct? Do you know, Dr. Grimm?
What was the question?
Still a vacancy down at Nowata?
Thank you.
I'm gonna have to review that to be sure before I answer.
Okay. And the referral approval rate, I noticed an uptick in that when we sent the group down the road. So when is this transition going to take to get them back in the Claremore Hospital area?
I believe they're still in there. Yeah, we've never moved them down the road yet. That was just upcoming, and because we presented it to you in advance and there was a lot of displeasure, we actually are getting it worked out so they're never going to have to be out of the facility.
I become acquainted with Mr. Terry. That's pretty good. So, I noticed over here on the RVUs, I think that's what that is.
Yes, sir.
Everything is down except Ocean, J, and Salina. Is that telling us anything or not? Or we don't know.
I mean, we really only have 3 data points right now, and so it's not, I mean, because of the number of, you know, holidays there might be in that time frame of people taking leave, you know, during that time frame. You know, what I ultimately want to see at least here is 5 data points for you. And that'll be a 4th quarter and then the 1st quarter of next year, so that we can see a whole year's worth of data plus the same time last year. But we're going to see fluctuation like this from quarter to quarter based on the number of days in that quarter, the number of holidays in that quarter, and things like that. And, you know, we're not sure what is a new norm for that. And
so this was Q2 that I see.
Q3 is the latest that you have right now. You have quarter 1, quarter 2, and quarter 3.
So quarter 3 is in that part of the...
Yes, that very end part where the downturn is on some of them anyway, upturn on others. But I'm looking at the top bar. It's an upturn for Oshaleta at the bottom if you look at Oshaleta. But yeah, right now you have 3 quarters. October, November, December is quarter 1, January, February, March, and then July, August, September. The thing about that quarter 3, when you were talking about, I'm assuming that was the one you were talking about, downturns. You know, July, August, September, there's a lot of people that are taking vacations in the summertime too. Some of that comes, you know, in May and June, and some comes in July and August. So, like I said, we're not sure with the RVUs yet, the kind of ups and downs we're going to see that are normal ups and downs because of our benefit structure, number of holidays, and you know, some weeks or some months, you know, you end up having almost 5 weeks, if you will, others less. So,
I had a question from a couple of elders for their caretakers about they told me it was a 7-day script turnaround, and I think Jeff has sent me a message that it's really 5 plus a week. On the elders, is there no flexibility, or that's just it, it's a 5-day turnaround, or before they could get scripts ordered again?
I hate to say that's just it. We're flexible in that from situation. You know, we can't be hard and fast on everything, but as a general rule, that is the way the system is set up. I guess my concern is what problems they were having. We discussed that here. I think I put it in the email to you as well. And maybe we can further define where those problems exist. We can either look at a solution, or maybe have a reason of what's going on that they keep functioning and are able to actually further their management. There's got to be something deeper than just, I think, on the surface of not being able to use the phone system and call it in. So I want to be sure we look further into that.
And is everything, you can call in any script?
Want to call in any script?
Yes.
Yeah, we can. We prefer they use the phone system. It's considerably much more efficient. Really, the online refill system is the most efficient system we have, but we understand that not everyone, you know, is computer literate or has access to a phone, or they may have a huge list of medications that they don't want to spend 15 minutes on the phone trying to order them in as well.
And I think this is the area we're entering into when we get older, whenever that'll happen someday.
Yeah.
I think that's the area that I'm referring to. When I mention elders, the system sometimes is more set up for millennials than somebody in their 80s or maybe 90s. And that's why I asked about the flexibility.
Absolutely. If you have a difficulty with flexibility, then we'll have to see if we can certainly discuss that outside the meeting.
But it's not gonna be automatic. If somebody's past 80, you're not just gonna say, it's okay. I'll give you 7 days or 8 days.
You know, once again, we make that determination on an individual basis. I can't speak for everyone, you know, within the health system that works on the pharmacists and technician staff, but as a general rule of thumb, you know, we do try to work with our patients and help them out to the best of our abilities and theirs.
We can take a look at it, Counselor, if it's a problem, being a problem across the system, about, you know, potentially setting a policy.
Well, it seems like we've been here before. It's been a while, but I think we've discussed this before.
It came about actually during the 90-day discussion, if you remember.
That was part of it.
Quite some time back.
That's part of it.
Yeah.
And the 90-day discussion has a lot to do with this one. We're talking about older folks trying to get their scripts.
And that's where my concern is, and like I said, I'll be glad to discuss it with you offline. There's many facets, I think, to this other than just, you know, where the difficulty level lies, whether it's, you know, from a patient perspective or it's truly maybe within the patients themselves, who could use further assistance or help.
Not sure I hear what I want to hear. I don't mind debating it a little bit.
Okay.
I won't take up any more time.
But what I hope you're hearing is, you know, we're more than willing to work with patients to meet their demands and needs within our health system.
And if we do see that it is a problem across the system for patients over a certain age, to just use an example that you've been using, we can look at seeing if there's something that we can do consistently.
Well, let me say this. I recall the 90-day controversy. That had to become a law before you guys paid attention. And we don't want to go down that road again, do we?
Nope.
Okay.
We do not.
Thank you.
Counselor Hatfield, did I see your hand again?
It was. I forgot my question, but I thought of something else.
You can always call me later if you remember.
This is short and sweet. I like the reports where you do the charts and all the numbers, and that's great. But and this has probably been going on. You know, you've got the patient access, you have a little and that's what I understand. So I appreciate. But I forgot what the other question was. But I just wanted to tell you, I like this format, and it says patient access, and I like the comprehensive cancer control program. I think it's, you know, it's very important that you know, we're addressing probably those things, and we probably have for a while. But anyway, I like when I can read. The charts are everything, they're pretty, but you know.
And we have.
You've probably been doing this, but.
We have a really good, and we don't talk about it much, though. You know, it doesn't get a lot of airtime about our comprehensive cancer control or our cancer registry. You know, it's a big deal for a tribe to have their own individual cancer registry that's certified. And we do have something on, you know, this shorter report about the breast and cervical cancer program, you know, the number of people we screened this month for breast cancer. But you're right, we do have a lot going on in cancer control.
And the numbers are here. I mean, they're on the charts, but I like, you know, the actual numbers are there, and it's more meaningful to me. That's me personally, but thank you. Thank you, Chairman.
Yes, and in addition to Counselor Hatfield's comments, I'd like to add on the American Cancer Society that you're all going to planning together to show the film on HPV, Someone You Love. It doesn't say where or when, but will that be shown more than one time, or will it be made available to our Cherokee Nation citizens?
I'll find out
Okay.
if it's going to be shown where and how many times.
Sure. Councilor Burke, Speaker Burke.
You good, whatever. I like the format of your report, Dr. Grimm. At one time, we were talking about elder service here, and I know, like Councilor Lay said, we don't really need to do legislation. I think we can take it case by case, and there are exceptions. We had at one time either agreement or legislation back when I first got on the councils. And this wasn't only in healthcare, but it was in all services for our elders of like a certain age. Donated foods, instead of waiting in line, take care of those elders first. And I think without legislation, we all have to have that mindset. And if we can do that, then we don't have to really put it in writing, but we also want results with that.
I hear you, sir.
Okay, all right, thank you, Madam Chair.
Councilor Walkingston.
Thank you. I'm more concerned about our hospital at Hastings. I know a third-party revenue over there is approximately $70 million a year, and I know the CMS has been the big talk, and it's been quiet. And, I mean, other people may have been hearing about it, but it's been a quiet topic to me. I think the deadline was the October the 31st for them to renew our status as being a CMS accredited. Saying that, have they made their unannounced visit yet?
No, they have not. And we have a new deadline now. It's been extended because of their scheduling. They're busy with all these. You know, we told you that this is a year that they were doing validation surveys across the nation. They were following behind DNV and JCAHO and going to facilities and validating, you know, the findings that those two entities that do surveys on their behalf were doing. So they pushed our deadline out a little bit. We have a consultant group that we've been working with, as well as our staff have been working very, very hard. We've got all the things completed that were in the focused survey findings, and we've had an outside consultant group take a look at it and say that you know, we went above and beyond to fix those things, and we're continuing to just have them take a look at our entire service line and see if there are other things we can improve in anticipation of them coming back. But they haven't come back yet, but I feel like we're in very, very good shape. And one of the things I say is, you know, every day that they aren't here, we are making improvements. And so, you know, the longer it takes them to get back, the more things that we're improving service-wise.
What I'm hoping, and it's just like the State Department of Education coming in and doing a survey on a school. If they have it in for you, they're going to find something wrong, regardless how perfect and how above and beyond you are. And I'm hoping that's not the case with these folks and us, because your staff does do a great job, and you know, getting a consultant firm to go above and beyond to be sure that we're in compliance with those CMS standards is a lot, because 70 million that we don't have is going to be detrimental to our health care that we provide to Northeast Oklahoma. So I know you got a lot on your shoulders, but I appreciate you giving us that update. And whatever comes to this, I know you've taken every measure possible to make this right for our people, and I commend you for that.
We have, our staff have done an outstanding job of making those improvements, and appreciate your words.
Thank you. Thank you, Chair.
Okay. My first question, probably Mr. Hale might want to answer it. Can you tell us how to connect to the lactation nurse? This is something we've needed covered for about 2 months.
Yes, in the Women's Health Clinic, they have information about when those are scheduled, and it's posted throughout the Women's Health Clinic, or they can call up there and ask. If they want to call and ask for either Mary Martin or Sherry Cottrell, they can give them the
So the Women's Health Clinic. Okay. And you don't have to be a WIC. Anyone can call for that.
That's correct.
I appreciate that. Thank you so much. And the next thing, I wanted to ask, we did a provider survey. It's coming up soon. It'll be a year. Any chance we can repeat that again to see what our status is from then to now, to see the progress?
We plan on repeating it again, but not like soon. We have identified a work group. You know, we had talked about putting a work group of providers together to help make recommendations to management about things we could do to improve the environment, you know, that they work in. And I use that term sort of broadly to encompass a lot of things, you know, the environment that they work in. And what I'd like to do is wait until they have any findings, wait till we've had an opportunity to try to implement some of those, and then do the resurvey. And you know, we said 12 to 18 months roughly was the time frame. Now it's maybe looking more like 18 months.
18 months. Will you let us know what their findings are? Can you share that with us?
Their recommendations,
Yeah, the recommendations would be wonderful to have. I'd like to ask you, on scheduling our dental appointments, how often is the scheduling open to schedule a dental appointment?
Now, I know there's also somebody behind me that can answer that, but I'm going to give it a try because he's got laryngitis today. So I believe the way that we're doing that in dental right now is that it is open every day. So you can call in every day, but they schedule, I believe, it's 30 days out. And so whenever they've filled that one day, it's open every day, but then they fill that day's worth of appointments at that particular facility, and it closes down again, if you will, and it just keeps going like that so that they don't get, in the past sometimes we've been booked out 6 months or 7 months, and then people forget, or it really is not good when you're scheduled out that far. And our dental clinics, all of them allow emergency walk-ins, so if somebody does have something, then they can come in and be seen that day at a location. Did I get that right, Dr. Jones?
Yeah, on return visits, they're scheduled at chairside, so they don't have to go through the process every time. So once they're in as a patient of record, then they're scheduled each time. How
often are your
new patients are what Dr. Graham described as new patients. So
okay?
New patients coming into our system, we will have every one of our providers do 4 new exams every day. So depending on the number of providers scheduled for that day, they have 4 slots for brand new patients every day.
Question, are the phone lines to make those appointments open all day? I mean,
there's a certain time each day that we take those calls it's at 4:30 each day.
You take the calls to get a new patient in at 4:30 p.m.
Till the end of the day, yeah.
At 4:30 p.m. is the only time you can call and hope to get a phone line in to get a new patient appointment.
If you have an issue where you need to be seen immediately, it's the same day every day. Every day is open for patients to be seen if they have issues that need to be seen. But for a new patient for a comprehensive exam, we have those set from 4:30 to 5:30 every day at the end of the day. We used to do it in the morning, and people thought that was too much to try to do it in the morning because they were trying to get to work and things like that. So we listened to the patients that had comments, and we moved it to the end of the day from 4:30 to 5:30.
What if I am new to the area, or I've been here forever, I just haven't had to use the facilities, and I have a toothache? Am I a new patient, or can I be a walk-in?
Same day.
You will get them in the same day.
Same day. If you have a toothache, you'll be seen same day. And we have to stay till 7 o'clock. We stay.
Okay, I appreciate that information. I just hope everybody has the phone abilities to use at 4:30.
Yeah.
Okay, thank you.
No.
Next question. I want to talk to you about patient referrals. If I were a patient and I needed to be referred, is it better for me to make my own appointment with where you're going to refer me, or wait until Contract Health notifies me you're going to approve that? Because the feedback I have gotten has been that by the time Contract Health approves it, that some time has passed that would have given them time to see the specialist in a more timely manner.
I'm going to politely disagree in one instance, because we approve those the day that the patient is seen. The next day those are reviewed, and the patient is usually notified 2 days to 3 days after they were seen. Now, if the patient 3 weeks ago knew I need to see an ENT specialist or something, and they made their appointment way back 3 weeks ago, so it kind of depends. But at one point we were only doing review of all the referrals across our system 1 time a week, and we heard from you all and from our patients and from our leadership, the chief's office, that we needed to try to improve that. And we went from, I want to say we have 2,000 to 2,500 over the course of a week that we would then be reviewing, at the end of a week. And then unleashing that across the system to start making appointments. Now we do that on a daily basis. So I'm not sure if, you know, we've tried to improve that, so I don't know if I really understand your question or if I answered your question or not, but we've tried to improve that process to be as rapid as we can after their visit. The problem is that I think some patients don't realize is, depending on the type of specialty, you know, it may take weeks before you can get in to see them, and we really can't do much about that. I mean, that's just, you know, the way it is. I had an appointment with a particular type of specialist and had to wait 8 weeks to get in, you know, just because that's how far out they were scheduled. So, you know, I mean, we have to deal with the demands in the private sector marketplace where we're referring people. And if we know somebody needs to get in urgently, you know, for something, we have enough of a relationship with a lot of these providers because we send them a lot of, you know, different patient volume across the year that we can, you know, Steve or Dr. Montgomery can call them and say, you know, we really have somebody that needs to get in quick, like within a few days. And can you call us if you have any cancellations? And we do that, you know, we can do that regularly if we have urgent things. You know, if somebody has something very serious that needs to get in and this type of provider is 8 weeks out, you know, normally, we will keep their name by us, and when they call, we call the patient and say, you can get in tomorrow or you can get in 3 days. And we do that regularly. And I'm not sure how, you know, we constantly work on trying to improve that, but so I'm not sure exactly if, you know, you had somebody complain about something that we could improve on, or if it was one of those things where they just needed a referral and it was the kind of specialist that was 3 weeks out, 6 weeks out, 9 weeks out normally in the private sector.
That's probably what it was. It was a specialist like that. Thank you for that. I was curious, do you have the panel report from Hastings? The findings?
No, not done yet.
You know, for an event that happened in April, may I ask what's taking so long?
Well, scheduling with people is part of it, and I'll take responsibility for part of that being my, you know, my availability. But one of the things I want to assure you, and one of the things that we had a draft of the report during our last meeting, and we're adding to that based on discussions at the last meeting. And I'll say one of the things that the group felt very strongly about being said in that final report very early on in it is that even though it has taken this group, you know, some time to get a report done, that they want it known that the staff that have been involved in trying to make the improvements have been working huge number of hours, have made a lot of improvements, a lot of programmatic changes in over this period of time. And so the fact that this report hasn't come out in no way really affects the amount of work that's been done or the things that have been improved, because we've essentially been visited 4 times, if you will, now. We had our normal DNV survey, which had some findings. We had 2 focused surveys from DNV and then CMS, and then we consulted, you know, we got a consultant group to work with us as well to make sure that we did everything we possibly could, not just in those arenas, but, you know, in sort of all service lines. So, you know, normally you have one of those kind of visits a year. We've had 4 in this short time frame, and we've made the improvements, you know, that have been found to be needed. So just the fact that the report will have some recommendations, including, you know, that all the recommendations made by those groups, you know, need to be carried out. Many of those have already been done, if not most of them. So I want everyone to know that just because that report's not done, has nothing to do with the fact that the system's not made the improvements they needed to make.
Thank you. Could you tell me if the nursing leadership who failed so miserably, causing us to have these 4 situations happen in the last 6 months, are they still employed? I mean, they failed miserably in orientation, I think infection control. In reading the reports, pharmacy provided them, and not, I mean, I can just go on and on. Is this leadership still employed?
I can't speak about employment-related matters here.
Okay. Because I think that the reason we've had these 4 things is because this leadership failed us so miserably. And I'm here to voice that opinion. I want it known that when you have a new employee, you orientate them properly. You have procedures in place. And for someone not to see what was happening in that small of an environment, I mean, I can't imagine. I would let multiple employees go in this situation, and I would start at the top. That's just my 2 cents on it. I want to share that, though. I want it to be record that we are failing our citizens when they have not done their job. It's wonderful they're deciding to do it now, but we have paid them, I don't know how much dollars, to do the job that they have failed. And I think we need better leadership.
I hear you, Chairperson.
Thank you. And then my last question, well, actually, it's kind of 2. Can we put our formulary on the line for pharmacy?
We can. We actually have it online. I think it's only internally right now, but it would be easy to do. You bet. Maybe we can get with the Cherokee Nation IT folks and our IT folks and get them to put it online. If it's nothing secret, I'll supply a copy to anybody that wants it.
I appreciate that. I know there are a lot of patients. I think you would appreciate that as well. And tell me, do we have a website that is updated on our healthcare? And is that something we've considered if we don't?
You know, we have a website out there. I don't think we have made, as much use of it as we could. We're making, I'll say we're making advances in the way patients can access their health records and things like that, more so than what we're doing with the forward-facing, thing that shows our clinics and what services are available. I mean, we have that, and that doesn't get updated, regularly, but what we've been focusing on is our electronic health record and patients having access to the patient portal, so that they can get in and look at their records and their lab results and things like that. So we've been focusing more in that arena than the other, and we could dust up that better. I'm sure we could.
Dr. Graham, I'm sorry, Counselor Dobbins, go ahead.
I just wanted to comment on, Dr. Jones had mentioned that our clinics see all dental emergencies the same day. Now that's a mouthful. That's a level of care that you don't see in other healthcare systems. So I think we'll applaud our dental clinics to do that, because our citizens, I would advise them to walk in at 5:30, but they are seeing the same day, and you don't see that level of care in other healthcare systems or even private practice for that matter. So I didn't want that to kind of go unnoticed.
Thank you.
I think that is wonderful. Counselor Crichton, very quickly.
Real quick. All right. Will you give me a quick update on the Stillwell, the progress they're making on the new construction?
Architectural documents are still going, and what we're hoping is that sometime early after the first of the year, we might be able to get started on it. We're talking about trying to, this is very detailed, but prices may go up on steel after the first of the year, I've been told, and so we may try to get a steel package bid out even before that, so that we can do a little money saving. So we're continuing to work on it. I know it just seems like it's not making much progress, but all the planning stuff beforehand, takes a while, and as soon as we break ground and get going, everybody will be able to see the progress.
And I don't point fingers at you. There's a lot of in this, but now those documents, I've heard that quite a few times. But just any new thing, if you just shoot me an email, and there's folks that seem to have some information kind of before I do, and there's folks that need that information before I do, as far as the medical field. But and just so I'm clear, we have, like at Hastings, we have each dentist has 4 slots for new appointments. Is that right? And
That's across our system.
okay, so if someone would say, I can't get an appointment for X amount of time, a new appointment, that's really not true.
Well, you know, they got to call in, you know, it's that, if they're a new patient, like Dr. Jones said, if they're an existing patient, they'll give them the next appointment and they'll give them their 6-month follow-up appointment. But if they're new, there's this rotating, you know, if you get there, if you get called that day and you get in, then into those appointments, you get it. If not, you got to call back the next day and the next day. And some people get frustrated, and I understand why, you know, that, well, I've tried to call every day this week and I didn't get in early enough to be able to be one of the ones that got an appointment, you know. And
So like at Hastings, like how many dentists in a given day are there, Doctor?
Depends on, you know, on a given day, because we have specialists rotating in and out, and they take chair time up. So generally it's 12, or it's 3 dentists, 4 appointments, so generally it's 12 per day. But it's, you know, when we get expanded to a bigger facility, it'd be more. A place like Oshaleta, we have 4 per day, because we have 1 dentist.
All right.
So that's depending on how many we have scheduled, and if they're scheduled off for leave or, you know, for vacation or something like that, then obviously that total goes down. That's why we keep it 30 days out.
So potentially 12 times 4 at Hastings.
And we're running
new.
Three dentists with 4 appointments each, so there's 12 appointments.
Okay.
And we're going to expand, you know, the number of operatories at Stillwell when we do this renovation too.
Well,
And that number could fluctuate a little bit if a specialist is there and they're taking up a couple of chairs, then dentist may only have 1 chair workout, so we only have 2 available today. We base it on each dentist having 2 chairs available.
thank you.
Counselor Buzzard, yes.
This report, back to this and all, I like the report. It's pretty clear and it's nice, and you can look over it fairly quick to see what's going on. But I also like the stuff in the book, like Counselor Hatfield said a while ago, there's some good information. I just want to bring up one other thing. Dr. Graham, I had a person to call me and said that we'd sent 40-plus people from Health IT to Kansas City. And I guess it's to learn more about Cerner. I'm not sure what it was about. But I also was told that we have a high-paid contract that also went up there to take the training. So when I heard that, I kind of questioned it. You know, you send 40-some people to Kansas City, pay per diem, per day travel, pay hotel rooms and stuff like that. Managing, it looked to me like we could have hired somebody from Kansas City to come and do that training for 40-plus people. So check into it if you would.
I can tell you a little bit about it, and I don't. The number I heard was 30, but I don't know. You know, 30, 40. That's still a big number, but that is Cerner's big health conference that they put on for all their clients.
I see.
There was around 12,000 people there. So you don't get that quality of continuing education if you bring a couple of people to Tahlequah. And for a lot of our IT people, that is their main training, and some of our health people go to that too, because it's not just an IT conference, it's a health conference too. And I was talking to some of the folks about some of the speakers there and some of the things they had, and it's a lot of cutting edge and futuristic things, you know, in healthcare. I mean, it was a quality conference, worth the time, you know. But
okay, well,
but it may not have looked good to some people.
It was brought to my attention. I said, well, I'll ask. So,
yeah.
So okay, thank you. Thank you, Madam Chair.
Y'all, we're about out of time. I want to end my speaking here with Dr. Grimm. I want to tell you something. In the past year, we've made so much progress on this committee, and I applaud everything you're doing. I think you're doing a wonderful job. I know your hands are tied in many ways, and you inherited situations, but I want to tell you, I'm really pleased in the direction you're taking our healthcare system.
Thank you. I really appreciate your kind words and all of your all support.
Okay, any old business? Any new business? Our next meeting will be scheduled for November 13th at 1 p.m. Take a motion to adjourn. So moved. All those in favor? Aye.